Welcome to this video recording of the latest guideline chapter, Diabetes and MASLD in Adults. Thank you so much for joining this session. My name is James Kim. I'm a family doctor from Calgary. I'm also working as a clinical assistant professor affiliated with the Department of Family Medicine at University of Calgary. And today I'm joined by my co-lead author, Dr. Giada Sebastiani, professor of medicine, clinical scientist, and hepatologist in McGill University. And both of us are fortunate to be part of the Global MASH Council.
This webinar has been brought to you in partnership with Novo Nordisk.
So I hope that you enjoyed the chapter. I hope you found this to be interesting. So we published this guideline on August of 2025. It was the first guideline in the world, as far as we are aware, that has a dedicated chapter in the diabetes guideline on this condition called metabolic dysfunction associated steatotic liver disease, what we are going to call it as MASLD. We are very excited about this guideline, and it has received a lot of international attentions and actually a lot of praises from the International Liver Society and liver community. So I hope that you also find it very useful. It took a long time to come up with a brand new guideline chapter. I feel like I lost a couple of my years of my life, my hair, gained weight. Anyway, we spent a lot of time on this guideline, and with the latest evidence that were available during our search period. So why did we, in Diabetes Canada, decide to come up with a metabolic dysfunction associated steatotic liver disease chapter? Well, the first thing that we should appreciate is the fact that this is the most common liver disease in the world, with a global prevalence being about 38%. In other words, 1/3 of the global population has this condition called MASLD. Now, if you have someone with type 2 diabetes, then the prevalence goes up to close to 70%. 69% of people living with type 2 diabetes have MASLD, and 37% of the people living with type 2 diabetes have MASH, which is the more severe form of MASLD. And about 15% of them actually have an advanced liver fibrosis. So think about it, 15% of the people living with type 2 diabetes having an advanced liver fibrosis with a whole host of complications that I'll explain shortly. Most people with MASLD actually suffer from cardiovascular disease and die from cardiovascular disease, followed by non-hepatic malignancy being the second leading cause of death, and then followed by liver-related conditions such as liver cirrhosis and liver cancer. So this is a really potentially an independent risk factor for cardiovascular disease, according to some of the experts. It does incur a huge healthcare cost, and it is fast becoming the #1 cause of liver cancer and liver transplant in North America. I have heard from a hepatologist from US that they are actually quite concerned that they are running out of liver to transplant just because of MASLD-related liver cirrhosis and liver cancer in US. So it is really scary, and it seems like Canada is following the suit as well. This truly is a liver's metabolic manifestation of metabolic syndrome. Yes, this is a condition that happens in the liver. However, it is a metabolic manifestations. It is a systemic disease as well. And type 2 diabetes seems to be the major risk factor for liver fibrosis. Therefore, it was felt that within Diabetes Canada, the guidance is necessary in screening, diagnosing, and managing people living with MASLD in type 2 diabetes population. So we assembled what we call an A team, so Avengers team or A team, however you want to call it. So myself, James Kim from a family medicine. Then we had two excellent hepatologists whom I have learned a lot from during this process. My co-lead author, Dr. Giada Sebastiani, hepatology, and Dr. Alnur Ramji from BC, who's also a hepatologist. Then we had one of the leading endocrinologists, Dr. Harpreet Bajaj, as the author, and also Dr. Chantel Bamir, who's the nutrition expert from the University of Laval. So we had multiple PICO questions focusing on the background, screening, non-invasive test, health behavior interventions, pharmacologic treatment options, and cardiovascular protections. And all these PICO questions were submitted to McMaster's evidence review and synthesis team called MASLD. And we had about 500 articles that they came up with that we sieved through and to come up with the guideline recommendations. So we have the MASLD guideline, and the overview is as follows. So we started off with an introductions, and we felt that it was very important to talk about the nomenclature change from NAFLD, which is called a non-alcoholic fatty liver disease, to MASLD, and then to talk about the epidemiology and the method of how we actually came about with this guideline. Then we proceed to talk about the pathophysiology and natural history of MASLD, screening for MASLD and liver fibrosis, health behavior interventions, anti-hypoglycemic agents used in MASLD, vascular protections of MASLD, followed by conclusions. So let's talk about the nomenclature change. So why was there a terminology change from NAFLD to MASLD? And to be honest with you, this was a bit of a curveball during the writing process, because this terminology got changed while we were developing the guidelines. So it was a bit of a curveball, but I think we were quite happy with the new terminology called MASLD. So NAFLD is a formal nomenclature. It stands for non-alcoholic fatty liver disease. And the reason why the decision was made to make a change to MASLD is as follows. So we felt that the NAFLD, or non-alcoholic fatty liver disease, does not really identify and specify the fact that this is a multi-system disease that happens from the liver. So this truly is a systemic conditions. And it really does not accurately reflect the disease etiology. This is not a non-alcoholic related conditions. This is truly a metabolic condition that happens in the liver. And then the name non-alcoholic fatty liver disease does not really reflect that. And this was actually a diagnosis of exclusion, which is really unfortunate. So I think it is important that we have to talk about why the terminology got changed from NAFLD, also known as a non-alcoholic fatty liver disease as we knew, to now MASLD. So the term NAFLD poses a number of challenges. First of all, it really did not identify the multisystem impact of the disease, because this really is a systemic disease that happens in the liver. It does not accurately reflect the disease etiology as well. So non-alcoholic fatty liver disease sounds like the etiology is because there's no alcohol in it, which is not true, because this is really a metabolic issue. And this was actually a diagnosis of exclusion. And finally, there was a potentially stigmatizing language with the word fatty, and that term got changed to steatotic to make it less stigmatizing. And NASH, which is known as a non-alcoholic steatohepatitis, now got changed to MASH, which is a metabolic dysfunction associated steatohepatitis. So what is MASLD? By definition, it means that you have to have a hepatic steatosis, which means a fatty deposition in the liver, with one or more cardiometabolic risk factors, which are prediabetes and diabetes, overweight, obesity, hypertension, or dyslipidemia. This is the diagram that we came up with, and would like to thank especially to Dr. Felice Sink for helping us to come up with this diagram and this algorithm, which actually became quite popular on the internet within the hepatology world, which we're quite proud of. So this algorithm says that if you have a steatotic liver disease, evidenced by the imaging or biopsy, then the first question we have to ask is that, are there any cardiometabolic criteria? As mentioned, those are prediabetes, diabetes, overweight, obesity, hypertension, and dyslipidemia. And if they do have steatotic liver disease with one or more of the cardiometabolic criteria, then you should look for the other causes of steatosis. And if they are none, and often they are none, then you can actually assume that the person has MASLD, or they are diagnosed with MASLD. If there are other causes of steatosis or fatty deposition in the liver, then you could consider them having a MASLD, which I will explain on the next slide, or other combination of etiology. Now, if the patient does not have other cardiometabolic criteria, then we should look for other causes of steatosis. So if you can't find the other cause of steatosis, then it could be ALD, alcoholic liver disease, or other specific etiology, which will often be handled by the hepatologist. Or if there are no other causes of steatosis, then we call this cryptogenic steatotic liver disease. But we decided to simplify this. We took the international guideline and we just made it a bit simpler. So the most common cause of steatotic liver disease is by far the MASLD, metabolic dysfunction associated steatotic liver disease, as you can see on your left-hand side, and also MASH, which is the more severe form of MASLD. And then we're going to skip the middle section and we're going to go to the section on the right-hand side. So then you'll get a patient who drinks a lot, then you'll get an alcohol-associated liver disease, or also known as alcohol-related liver disease. We call it ALD. And then we grouped a whole bunch of the other rarer steatotic liver disease conditions as others. Now, what happens if you have a MASLD and someone who drinks a little bit more than what we would like them to? So if you're a male and if you drink about 30 grams of alcohol per day, and if you're female, about 20 grams of alcohol a day, then there would be more with the MASLD predominant MetLD. So MASLD and increased alcohol intake patients, we call them MetLD. And if they happen to drink about 20 grams of alcohol as a female and 30 grams of alcohol as a male, then they would be more MASLD predominant. Or if they drink a lot more than that, which is 50 grams of alcohol as a female and 60 grams of alcohol as a male, then they will be ALD predominant MetLD. So that's more of a spectrum of the condition. So this is a very important concept and nomenclature that has been developed to encompass all the patients that has a MASLD and who happens to drink a bit more than we would like. So what is a MASLD versus MASH? Because some people are confused as if these are two completely different liver conditions. So let me explain. So you get a healthy liver, and then when the fatty deposition starts accumulating in the liver, then we call that simple steatosis or MASLD in some cases. So MASLD is a metabolic associated steatotic liver. So it's not really in a disease state per se. Then, if this progresses, then it becomes MASH, which is more severe form of MASLD. So this is when you get the steatosis, so fatty deposition in the liver, plus inflammation of the liver. So hence the hepatitis. Then you get the fibrosis, so scarring of the liver. So you can have the like no fibrosis of the liver, but still has the fatty deposition and inflammation of the liver. So we call that fibrosis stage 0. And from there, as the fibrosis or the scarring happens, then depending on the amount and the severity of the fibrosis, we'll call that fibrosis stage 1, 2, 3, and 4, and fibrosis stage 4 being cirrhosis. Now, there was a more terminology that got developed. So F2, so fibrosis stage 2 to F4, which is a fibrosis stage 4 or cirrhosis, we would call them a significant fibrosis. And if someone has a fibrosis stage 3 to 4, then we will call that advanced fibrosis. Now, so would like to start discussing more about the actual recommendations, and would like to hand over to Dr. Sebastiani to take us further.
Thank you so much, James, for the great introduction. And I would like really to echo your enthusiasm about this first MASLD chapter within the Diabetes Canada guidelines. And I really feel like yourself, we had a very insightful and transformative journey during our production of this MASLD chapter, and in a very multidisciplinary group and holistic approach to the disease. So as Dr. Kim was saying, MASH is actually the most important in terms of prognostic entity within the MASLD spectrum. And one of the dreadful complications that actually lead the prognosis of the disease is liver fibrosis. And because of that, recommendation 1 of our our chapter is dedicated to screening for liver fibrosis. And I would like to show you the prelude of this recommendation. The prevalence of significant liver fibrosis is increasing, and it is associated with increased risk for cirrhosis, hepatocellular carcinoma, and premature mortality. And it appears that insulin resistance and metabolic syndrome are the key underlying features. And obviously, this is especially important in a population like people with pre-diabetes or type 2 diabetes. Therefore, consider screening all individuals with pre-diabetes or type 2 diabetes, especially with the features of metabolic syndrome, for MASLD-related liver fibrosis by measuring ALT, AST, so the liver transaminases, platelets to calculate the FIB-4 score to detect advanced liver fibrosis with the grade B and level 2 recommendation. And this is really the core, the heart of recommendation 1. If we go into the details of the FIB-4 score calculation, this is actually a very simple serum biomarker based on age, AST, ALT, and platelet count, so parameters that are readily available in clinical practice of all physicians caring for patients with prediabetes or type 2 diabetes. And going more into the details of the recommendation 1, it's important to underline that we recommend FIB-4 score rather than only measuring ALT and AST. Unfortunately, many studies have shown that only measuring ALT and AST is not enough to rule out advanced liver fibrosis. We really need the calculation of FIB-4. And more in details of the recommendation, this leads us to identify individuals require further investigation, follow-up, or referral due to increased mortality and morbidity. Grade C, level 3. As I was telling you, liver fibrosis is the main driver of the prognosis in patients with chronic liver disease, including MASLD. And now I would like to show you what is encompassed in recommendation 1 as a clinical algorithm that you can use in clinical practice. Recommendation 1A, so the subgroup, the sub-recommendation 1A, state that in individuals with low probability of liver fibrosis, so FIB-4 less than 1.3, manage metabolic syndrome and consider repeat screening with FIB-4 every 1 to 2 years. This is the general algorithm that we will dissect into details. As I was telling you, recommendation 1A really focus on the fact that patients who have a FIB-4 less than 1.3 can be safely managed in primary care or endocrinology clinical care because the risk of having advanced liver fibrosis is very low. This is the core of recommendation 1A. So in patients with type 2 diabetes or prediabetes, first you calculated the FIB-4. If it's less than 1.30, the risk of having advanced liver fibrosis is very low. So the patient can be safely managed in primary care or endocrinology clinics in terms of glycemic management, treat metabolic syndrome, weight loss, and reassess FIB-4 every 1 to 2 years. Consider, as we said, repeating this screening. So if we go into the other part of the algorithm, recommendation 1C in individuals with high probability of liver fibrosis, which is defined as a FIB-4 more or equal to 2.67, referral to hepatology is recommended with a grade C level 3. And this is especially related to recommendation 1C. You see the part of the algorithm that relates to this recommendation. So in these patients, the risk of having advanced liver fibrosis is significant. So you can do a direct referral to gastroenterologist or hepatologist. And in specialistic care, we will assess the chronic liver disease in terms of consideration for MASH targeted pharmacotherapy, consideration for screening of end-stage liver complications, including hepatocellular carcinoma and surveillance for variceal bleeding and esophageal and gastric varices. And finally, we go to recommendation 1B, that is the center of our algorithm. And as you can see here, in patients who have a gray area result for the test, which is defined between 1.30 and 2.67, we recommend to perform a second-line test that could be liver stiffness measurement by transient elastography or an alternative test, such as the ELF biomarker or the shear wave elastography. The recommendation states that in individuals with intermediate probability of liver fibrosis, additional testing may be performed to further risk stratify. And of course, if the second-line test is positive, meaning liver stiffness measurement over 8, for example, the risk of having advanced liver fibrosis is significant, so there is a need to refer to gastrohepatologist. In fact, referral to gastroenterology or hepatology is recommended if these tests are not available. So we actually introduced this extra recommendation, which is kind of a new tool in terms of diabetes guidelines focus on MASLD. And this is really one feature that we are proud for the MASLD chapter of Diabetes Canada, because we accounted for low resource settings in remote areas, rural areas. Not everyone has easy access to liver stiffness or other second-line tests. So if a physician consider that there is no such access, he could also consider a direct access, a direct referral to gastroenterology or hepatology for patients who have a FIB4 more than 1.30. This is the conclusion of recommendation 1, which is obviously the key in clinical practice, because it introduced the screening recommendation for liver fibrosis due to MASLD and MASH in patients with prediabetes and type 2 diabetes. Recommendation 2 focuses on the surveillance for hepatocellular carcinoma and liver cirrhosis. In people with MASLD liver cirrhosis, defined as a stage of liver fibrosis F4, routine surveillance is recommended with the grade D and level 4 by using ultrasonography and serum alpha-fetoprotein levels every 6 months to detect hepatocellular carcinoma, looking for feature of clinically significant portal hypertension to identify individuals who require upper GI endoscopy to find esophageal varices, clinical signs and symptoms of hepatic decompensation to optimize liver-related outcomes. And now over to James for the lifestyle modification recommendations.
Okay. Thank you, Dr. Sebastiani, for that excellent discussions on the first two very important recommendations. So let's talk about the lifestyle modifications. So recommendation 3 and 4. So recommendation 3 talks about the individuals with type 2 diabetes and MASLD-related liver fibrosis should aim for sustained reduction in body weight of 5 to 10% to improve glycemia, insulin sensitivity, and to reduce the hepatic steatosis. So we do feel that if you lose the weight of 5 to 10%, then these metabolic improvement will happen. However, if possible, then we do recommend the weight loss of 10% or greater for the increased chance of reversing the actual fibrosis. And we gave the grade B level 2 evidence. In other words, if you have a body weight loss of 5 to 10%, then yes, you can do a fantastic job in terms of the metabolic status of the patient. However, if you can go beyond that, so 10% and greater, we may be able to reverse the fibrosis, so from fibrosis stage 3 to 2, or fibrosis stage from 2 to 1, and so on. So the weight loss of greater than 10% is what we would aim for if possible. And then the recommendation number 4 talks about the other aspect of the lifestyle, which is an activity and diet. So individuals with type 2 diabetes and MASLD-related liver fibrosis should be supported to incorporate healthy behavior interventions, including physical activities and healthy dietary patterns, such as Mediterranean diet, that best aligns with the individual's value, culture, and preferences, and treatment goals, allowing the greatest adherence over the long term to achieve optimal glycemia, improve insulin sensitivity, and components of metabolic syndrome. And for this, we gave grade C, level 3. If you talk to a lot of the obesity specialists and ask them what is the best diet for the patient, and their answer is like 99% of the time will be the diet that the patient can stick with, something that they can persist with. So that's why we wrote that whole line on the focusing on the fact that it has to be best aligned with the individual's value, culture, preferences, and treatment goals. And really, the key is to allow the greatest adherence for the long period of time. Now, we do single out the Mediterranean diet, and the reason is that the Mediterranean diet has the highest level of evidence when it comes to MASLD. So that's why we did highlight the Mediterranean diet. Then we go to recommendation number 5, and this is when we talk about anti-hyperglycemic agents. So we talk about the 2 medications in this recommendations. In individuals with type 2 diabetes and MASLD-related liver fibrosis, fibrosis stage 2 or 3, then pioglitazone or subcutaneous semaglutide may be considered over other antihyperglycemic agents to achieve optimal glycemia, which may reduce steatohepatitis and progression of fibrosis. So let's take this into 2 pieces. So let's talk about pioglitazone. So pioglitazone received a grade A level 1 evidence. Now, pioglitazone, I am aware, and a lot of us are aware, is not a common medication that is being used, especially in the world of GLP-1 receptor agonist or the SGLT2 inhibitors. However, the research data on pioglitazone, especially in 30 and 45 milligrams, is so profound that we went back to the literature, we went back to Mer's team, and the answer was that there's no way that we could actually give lower grading than grade A and level 1 evidence for this pioglitazone. So it does have a pretty robust data on pioglitazone. I know there are a lot of concern about pioglitazone because of the weight gain, which is about 2% of the person's weight, can be significant, but most of them seems to be water weight. Heart failure or the worsening of the heart failure. So it seems like it's a fluid weight that the people gain. And the osteoporosis of bone fractures and so on, bladder cancer. Some of these seems to be myth, and then the link has been not well established. So people can get weight gain on pioglitazone. However, when it comes to MASLD-related fibrosis, the data is very, very strong on pioglitazone. Subcutaneous semaglutide, at the time of the literature search, the ESSENCE trial was not available, hence we did not talk about the ESSENCE trial. With the existing data, we could only give a grade D and level 4 evidence, and with the more subsequent data that are being available, I'm sure that in next iteration, the grade will probably be higher. Some of you may ask, what about tirzepatide with their Synergy MASH study? So that is a phase 2 trial, and that did not fall under our literature search period. Therefore, it did not make it into our guideline. And I'm sure in the next iteration, there will be some talk about tirzepatide on its impact on MASH as well. Now, to talk about the vascular protections, over to you, Dr. Sebastiani.
Thank you so much, Dr. Quinn, for the excellent overview of the interventions. So now I'm very happy to proceed with this theme in terms of interventions for vascular protection, which relates to recommendation number 6. So here you can see that individuals with type 2 diabetes and MASLD should be treated with statins. And I would like to clearly state that statins are not a treatment for MASLD, but they are extremely important, especially in this population where the #1 cause of mortality is cardiovascular disease, to reduce their cardiovascular risk. and they can be safely used even in patients with liver cirrhosis, but we do not recommend the use in patients with decompensated liver cirrhosis. So with a grade 4, level 4 and grade D recommendation for the use of statins. So I think here now we have a very nice overview of our MASLD chapter in the Diabetes Canada guidelines. And I hope that you have found this helpful, and I wish you to provide a summary integrating liver health into diabetes care. So why MASLD and liver health matters? Because MASLD is the most common liver disease globally, affecting around 70% of people with type 2 diabetes. This is the first Canadian chapter dedicated to MASLD in people with type 2 diabetes, and it relates to screening, diagnosis, and management. And specifically for the screening, which, as you've seen, is recommendation number 1, we recommend the use of FIB-4 score in all adults with type 2 diabetes or prediabetes and metabolic syndrome features. And you should escalate with elastography or specialist referral when needed. And we went through together the algorithm that we recommend in clinical practice. In terms of management, we heard from Dr. Kim very detailed interventions in terms of lifestyle. More than 10% weight loss is recommended to reverse fibrosis, and the most recommended interventions in terms of lifestyles are Mediterranean diet and physical activity. In terms of pharmacotherapy, pioglitazone or semaglutide are recommended for patients with F2 and F3 fibrosis. We also mentioned vascular protection because really MASLD is kind of a cardiovascular equivalent. Statins are safe and reduce cardiovascular risk and should be used generously in this population. In terms of the impact of our guidelines, is really we wish to align hepatology and diabetes care. We wish to support early detection, personalized treatment, and prevention of liver-related complications. So I really wish myself and my esteemed co-chair, Dr. Kim, to extend a special thank you to our reviewers, Dr. Mark Swain and Dr. Kenneth Cusi, to Tracy Barnes and Jill Toffoli from Diabetes Canada. Thank you to Diana Sherifali and Donna Fitzpatrick-Lewis from the MASLD team. A special thank you also to Dr. Felice Cinque, who helped us with the figures and the algorithm, and also to 2 members of the steering committee specifically, including Dr. Peter Senyo and Dr. Arpret Bajaj, for their great and discussion and helpful insight throughout the process of this new and first Diabetes Canada chapter on MASLD. Thank you very much for your attention.